Okay, I hope we're live. Lily, if we're not live, let me know. Anyway, it's great to be here 9/18/2025. It's always a little tricky getting these quizzes up because you can't really see what exactly you're doing. When you do a video, you can see yourself live. So here, I'm hoping that I am live. Anyway, dozen cases. Chest pain, 40-ish-year-old male, large anterior mediastinal mass, bilobed. A critical finding is some fat here. I don't see any calcification. You might think about teratoma when you see an anterior mediastinal mass with fat. Teratoma is a good thought, occasionally thymoma. You can see a very large lobulated mass, and so we probably thought this was a teratoma. This was biopsied, eventually resected. This was a primary liposarcoma of the anterior mediastinum. I'm not sure I've seen that case before. Okay, patient with cough. It looks like dilatation of the mid-esophagus, but is that a mass or not? When you look at the coronal views, it looks like there's something there. Maybe it's a foreign body, maybe it's a tumor, but there's something there. You need to go further. You maybe need to do endoscopy, but there's something in that mid-esophagus. You can see it very nicely on the PET scan. You put two and two together, what do you get? You get esophageal cancer. You could see it's very easy to look at this and say, well, there's just some fluid or reflux in the esophagus. So it's something you need to be very careful about and why those coronals are helpful. Chest pain and mediastinal widening. There's a posterior mediastinal mass, but a key thing is destruction of bone. So it could be a sarcoma invading bone, or it could be a bone tumor coming forward. You can see several vertebral bodies centered around T2, destructive changes, large mass pushing on the trachea. Could be lymphoma, could be plasmacytoma, could be metastasis, a neurogenic sarcoma, posterior mediastinum, and neurogenic tumors. Here's another look at it. This is not the best location for this diagnosis, but this was a chordoma. Remember, chordomas are base of the skull or in the sacrum. You can see here, sacrum, 50%, clivus or base of the skull, second most common, and occasionally cervical spine. Thoracic spine is uncommon, but that was the answer. GI bleed in oncology patient, marked thickening of the colon. It looks like thumbprinting. It's a severe pancolitis. When you see this kind of thumbprinting and the bowel is so thickened and it's so extensive, you're thinking about colitis, infectious and inflammatory. The one you need to think about, especially in oncology patients, but even not oncology patients, is pseudomembranous colitis, which this was. And again, nice thumbprinting. Hematuria, there's a mass in the right kidney, 37 Hounsfield units. Interestingly, as you go to later phases, the lesion never enhanced more than 20 Hounsfield units. Solid, well-defined. It's obviously a tumor. Clear cells usually enhance significantly. Papillaries enhance more than this. Oncocytomas have a central scar. The tumor that has minimal enhancement, well-defined, and is solid is going to be a chromophobe renal cell carcinoma. Again, they make up about 3 or 4% of tumors. They're typically less aggressive, can be resected, but something to think about. Left upper quadrant pain, big mass. From this image alone, you can't tell adrenal, renal, pancreas, but from this image, you can see it's pushing on the kidney. Classic epicenter for an adrenal lesion on the left. Large mass, 13.5 centimeters. You can go through a number of adrenal things, but when something's large, some vascularity, it has to be an adrenal cortical carcinoma. I have seen pheos this large, I've seen metastasis this large, but at the end of the day, since we see nothing else, you better really be thinking about this possibility of an ACC. Weight loss, paratracheal mass, multiple pulmonary nodules, liver metastasis, could be metastatic almost anything at this point. Then you scan down, there's a lesion in bowel. Maybe it's a small bowel adenocarcinoma with liver mets and lung mets that can occur. Maybe it's mets to all three places. Maybe it's lymphoma to all three places or four places. This ended up being worked up. This was melanoma with metastasis to bowel, to mediastinum, to lung, and to liver. Remember that melanoma and lymphoma often look very, very similar, particularly when they're multifocal. Incidental finding, tail of pancreas, looks vascular. I'm thinking perhaps a neuroendocrine tumor. You don't really see the spleen here. You see a small spleen. Could be a neuroendocrine tumor. Could you be dealing with an unusual appearing serous cystadenoma? That's a good thought. Or maybe even a large splenule. This was a serous cystadenoma. You can see it doesn't match the enhancement of the spleen. It could be a splenule. Serous cystadenomas that are solid and vascular can look identical to neuroendocrine tumors. We're doing some work to try to see if we can use AI to separate the two. Left upper quadrant pain, what am I looking at here? Very dense spleen. This is more than the appearance of a good bolus. It's really diffuse calcifications and a relatively small spleen. There's diffuse sclerosis throughout bone. You can see sacrum, iliac bone, and spine. There's some patchy decreased enhancement in the kidneys. You see the fish mouth vertebral bodies. You see sclerotic changes in the sternum. What are we dealing with? Well, the best bet is sickle cell disease, but all those variants, this was hemoglobin S with beta thalassemia, high density spleen autoinfarction, pyelonephritis, as this patient has, is not uncommon, and then the extensive bony lesions. Incidental finding, mass in the spleen. You can see on the later phase, you can see the mass, but it's a bit hard to define. Here it is really nicely on the cinematic rendering. Large masses in the spleen. Well, you could say it could be lymphoma, it could be metastatic. It's not angiosarcoma, it's not vascular. But incidental splenic lesions, hemangiomas, are a thought, but they have some enhancement. Solid masses, well-defined, sharp margins are typically going to be hamartomas. And this was a hamartoma of the spleen. I really do like the way the cinematics showed the lesion. Pelvic pain, complex cystic mass in the pelvis. Female obviously is saying ovarian cancer. But what else? The patient's in their 30s, ovarian cancer is a possibility. We didn't see carcinomatosis elsewhere, but that doesn't matter. This ended up being worked up. They did laparoscopic workup with biopsy. Ovarian cancer is still my best thought. This ended up being endometriosis. Endometriosis is a great mimicker, can cause small or large pelvic masses with or without septations, and can very much look like an ovarian primary tumor. So that, my friends, is about a dozen cases. I hope you enjoyed them. I hope you learned something from them. And I hope you have a great day. Be good.